Thank you for the kind introduction. Good evening. We'll start with the movement disorder section. The first talk is on treatment of early Parkinson's disease. So Parkinson's disease, you know that it is diagnosed when a patient presents with motor symptoms of Parkinson's disease, which include rest tremor, rigidity, bradykinesia, and postural instability. All additional features what we see in Parkinson's disease, micrographia, mass facies, decreased blinking, freezing, all will be stemming from one of these cardinal features. For the diagnosis of Parkinson's disease, the feature which is a must is bradykinesia, along with one of the other features, rest tremor or rigidity. Now, when it comes to diagnosis of Parkinson's disease, as I told, diagnosis requires demonstration of motor symptoms, which includes tremor, rigidity, and bradykinesia. But however, the motor symptoms become manifest once a significant amount of nigrostriatal neurons have been lost, which means that the neurodegeneration have been going on for quite some time, even before the diagnosis of Parkinson's disease. And the usual pre-motor symptoms include constipation, anosmia, REM sleep behavior disorder, etc. So why do we get these non-motor symptoms even before the motor symptoms? So this has something to do with the Bragg staging. You know, the disease progression takes a certain anatomical profile, in the sense like the synuclein deposition first happens in the vagus nerve and the olfactory nucleus, and then the medulla oblongata, and then it progresses to the midbrain structures and the cerebral cortex. So once the vagus nerve and the olfactory neurons are affected, we get anosmia and autonomic dysfunction, especially constipation. And once it goes on to the medulla oblongata, pons and locus coeruleus, we get a variety of manifestations, including depression, REM sleep behavior disorder, etc. By the time the neurodegeneration progresses to the midbrain, and once it starts affecting the nigrostriatal neurons, the motor symptoms will start. And the classical motor symptoms include tremor, rigidity, and bradykinesia. As the neurodegeneration progresses, it starts affecting the cerebral cortex, and all these things, whatever we are seeing, psychosis, cognitive dysfunction, dementia, all these pain, fatigue, all these things starts once the cerebral cortex is affected. Now, how can we stage Parkinson's disease? Parkinson's disease by the classical Horn and Air stage, as long as the patient is independent on activities of daily living, we consider it as an early stage of Parkinson's disease. And once they start requiring assistance for activities of daily living, we consider them as having advanced disease. However, there are other staging systems of Parkinson's disease also. So once they start having complications for medications, freezing, falls, a significant amount of cognitive dysfunction, they are termed as advanced disease. So which means that the early stage is further divided into early, mild, and moderate stages. So the true early stage of Parkinson's disease means that the patient only has mild symptoms. They do not have any threat to the activities of daily living, and usually they will not require any symptomatic medications as well. When it comes to the mild stage, the Parkinson's disease symptoms are already manifest and they require some amount of symptomatic treatment. And by the time it reaches the moderate stage, there will be some amount of complications, some wearing off, and some resistance to dopaminergic medications. So we will be discussing about the early and mild stages of Parkinson's disease, whether we need to treat, if we treat, what medication to choose. You know, as I told, when the Parkinson's disease neurodegeneration start, for quite some time, there will be no motor symptoms and patients cannot be diagnosed with Parkinson's disease. And once they are diagnosed, the initial stages, probably they will not require any symptomatic medications. And in the early stages, if at all they require some symptomatic medications, they have excellent response to these dopaminergic medications, in the sense like after taking the medications, they are as good as normal. No fluctuations, no wearing off, no dyskinesias ever. But this honeymoon period and this early stage will not last for more than 3 to 5 years. And then after that, some amount of motor complications will ensue, and that's the rule. So what are the therapeutic options which are available for Parkinson's disease? You know that Parkinson's disease pathology itself is because of reduced dopamine in the nigrostriatal system. So how can we treat Parkinson's disease? Essentially, we have to increase the dopaminergic levels in the nigrostriatal system. So what are the methods? One, you can substitute levodopa. Second thing, you can substitute in the form of dopamine agonist, or we can increase the synaptic dopaminergic levels by inhibiting the metabolism of dopamine by giving the metabolizing enzymes, which includes the monoamine oxidase inhibitors or the catecholamidyl transferase inhibitors. Not just dopamine has effect on the dopaminergic receptors, but it has some effect on NMDA receptors as well. So blocking the NMDA receptors will have some effect on the motor symptoms as well. So current available treatment options, is there anything that can slow, stop or reverse neurodegeneration in Parkinson's disease? This has been the daunting questions for quite some time. A variety of agents have been tried for this as well: selegiline, tocopherol, rasagiline, levodopa, pramipexole, and even gene therapies. But however, none of these studies have shown a proven benefit for reversing or slowing or stopping the neurodegenerative process of Parkinson's disease. That means once the neurodegeneration starts, it slowly progresses. So there is no effective neuroprotective agent as of now. So what are the current available options? All these available options are symptomatic medications for alleviating the symptoms of Parkinson's disease. Let us discuss with those which are required in the early stage. So most of the medications are effective as monotherapy in the initial stages of Parkinson's disease. These include levodopa, dopamine agonist, all those agonists including pramipexole, droperidol, rotigotine, MAVO-B inhibitors like selegiline, rasagiline, safinamide, and NMDA antagonist amantadine as well. So which one to choose? So you know that in the Parkinson's disease, whether it is in early stage or late stage, levodopa carbidopa continues to be the most effective treatment. But the problem is the emergence of motor fluctuations and dyskinesis after being initiated on treatment. So whether we start with levodopa or dopamine agonist or levodopa carbidopa entacapone, Stalevo, or should we give a MAVO inhibitor, or should we start on anticholinergics, amantadine? Which one to choose? Let us see one by one. Anticholinergics. Anticholinergics, you know that it will help tremor, rigidity, but not bradykinesia. And it comes with a variety of side effects, especially for the elderly population, which includes dry mouth, urinary retention, emergence of hallucinations, memory disturbances because it blocks the cholinergic neurons. So it's largely reserved for young subjects, especially tremor-dominant Parkinson's disease. Now, the amantadine, which is an NMDA antagonist, it affects the dopamine, acetylcholine, and glutaminergic systems. It results in mild improvement in PD symptoms because it has effects on the dopaminergic system, but at the cost of developing hallucinations, myoclonus, especially in elderly people. We have to be very cautious because of the renal clearance. So if there is a renal dysfunction, avoid amantadine. MAVO inhibitors, there are a variety of MAVO inhibitors which have been tried. The classical ones are selegiline and rasagiline. Selegiline is metabolized to the L-amphetamine metabolites, whereas rasagiline, there are no amphetamine metabolites, which makes it a more safer option to be started for Parkinson's disease. In one of the classical trials, ADAGIO trial, which was a delayed start study design, patients were made to receive rasagiline early in the disease or rasagiline 6 to 9 months later. And the researchers found out that patients who have been initiated on rasagiline initially into Parkinson's disease, they have a significantly improved UPDRS score even after around 6 years. So there has been questions whether it has a neuroprotective role, but further studies did not confirm the effect as a neuroprotective agent. The new agent safinamide, it's a potent, highly selective, reversible MAVO-B inhibitor and much more safer and very less side effects also. It also blocks voltage-gated sodium and calcium channels, and it reduces the neuronal dopamine glutamate release as well. The available doses are 50 and 100 milligram, and the current era, it is definitely indicated for early stages of Parkinson's disease because it delays the onset of development of motor fluctuations and dyskinesias. Levodopa, the most discussed and most suspicious one, especially for patients. So whenever a new patients come with Parkinson's disease, when we tell about the available treatment options, where they are always very resistant to be started on levodopa because they would have already checked in Google and has come up with all those dangerous side effects, including development of motor fluctuations, dyskinesias, and those terms like neurotoxicity, which was there for quite some time. So they come with a variety of questions. Will I develop tolerance to it in the future? Does it use up the good time? Should I only take the medication when I find it impossible to carry out my activities of daily living? Will it make the progression of my PD faster? So all the patients, they are very hesitant to be started on levodopa. So in fact, levodopa phobia is a difficult to treat disability in Parkinson's disease. Let us see why all these things happen. In one of the trials published in JAMA 2000, they they randomized into two groups, the early Parkinson's disease patient, and one group was given Pramipexole 0.5 milligram 3 times daily, and one group was given levodopa carbidopa combination 100 milligram 3 times daily. And they found out that initial Pramipexole treatment resulted in significantly less development of wearing off dyskinesias on-off motor fluctuations compared to levodopa. And they concluded that fewer patients receiving initial treatment with PD with Pramipexole developed dopaminergic motor complications than with levodopa. But of course, levodopa group had a better UPDRS improvement, resulting in better symptomatic relief. But you see here, there is a bias. If you calculate the levodopa equivalent doses, the Pramipexole group developed a levodopa equivalent dose of 150 milligram because 1 milligram of Pramipexole is equal to 100 milligram of levodopa. And levodopa group, they received 300 milligrams. So the first group received half the dose of dopaminergic medication compared to the second group. So further trials were necessary. But the further trials also noted that with Pramipexole treatment, definitely there is some delay in the occurrence of dyskinesias and motor fluctuations. But they have confirmed that it is not just with the Pramipexole treatment, it is something to do with the cumulative levodopa doses. So cumulative levodopa doses more than 300 is related to development of motor fluctuations and dyskinesias. And those who have motor fluctuations are more likely to develop dyskinesias, and those who have dyskinesias are more likely to have motor fluctuations as well. So that brought a need for trying levodopa to find out whether there is any neurotoxic effect or it is something to do with the dose of the medication. So L-DOPA trial, which is a multi-center trial, it evaluated the effects of levodopa in the progression of Parkinson's disease. They selected 361 mild PD patients. They randomized into placebo group and 3 doses of levodopa 150, 300, and 600 for a duration of 40 weeks. And they found out that wearing off and dyskinesias were significantly more common in the highest dose group, indicating that it has the development of dyskinesias and motor fluctuations have something to do with the dose of levodopa than with the type of medication. So another trial came up where they tried delaying the treatment with levodopa. So in a multi-center trial conducted in Ghana and Italy, they undertook this research question whether motor complications are primarily related to the duration of levodopa therapy or it is related to the disease-related factors. So levodopa therapy was given initiated early in patients in Italy, and levodopa therapy was delayed by around 2 years in patients from Ghana. So disease duration at the occurrence of motor fluctuations and dyskinesias was similar in both the groups. And they found out that The motor fluctuations and dyskinesias are associated with a longer duration of disease, longer duration of Parkinson's disease, and higher levodopa daily dose, and not with the duration of levodopa therapy. So those who have been initiated on levodopa from the beginning and those who have been started on levodopa around 2 years later, they developed motor fluctuations and dyskinesias in a similar fashion after a long duration of disease. So they identified some putative factors for the development of dyskinesias and motor fluctuations. They noted that longer disease duration, higher levodopa daily dose, long duration of levodopa therapy, which again indicates a longer duration of disease, young age at Parkinson's disease, low body weight, women, and those who have a more severe disease, as documented or as quantified by the UPDRS ADL score and UPDRS motor score, were more likely to have development of motor fluctuations and dyskinesias. The last trial came in 2019, where 445 drug-naive patients of disease duration less than 2 years were divided into two groups, one receiving levodopa 100 milligram for a duration of 80 weeks, and the second group, they received placebo for the initial 40 weeks, and the levodopa treatment was started 40 weeks later. So they received only 40 weeks of levodopa. And they checked for the total change in UPDRS from baseline to week 80. So in the delayed start group, you can see that the UPDRS total score definitely is more in the delayed start group, and the PDQ-39 indicating the quality of life also is much better in the levodopa group. So definitely levodopa initiation early into the disease improves the symptoms. Also, it improves the quality of life as well. And once initiated, the development of the dyskinesias or the total UPDRS score almost remains the same in either of the groups, indicating that delayed start did not have any effect, or early initiation of levodopa did not have any significant effect on the progression of Parkinson's disease, rate of dyskinesias, levodopa related dyskinesias, or any detrimental effect on patients with early Parkinson's disease. Now, dopamine agonists. A variety of dopamine agonists have been tried. The current most commonly used one are Pramipexole and rotigotine patches. So when they tried dopamine agonists, the researchers found out that when compared with levodopa, definitely the proportion of patients developing dyskinesias was more in patients with levodopa. And that means patients who have been on droperidol, they develop dyskinesias very late only. Also, they tried the same with Pramipexole, and they noticed that the patients experiencing wearing off and dyskinesias, it was much more with levodopa compared to Pramipexole. So, Pramipexole versus levodopa as initial treatment in a 4-year randomized trial, they found out that the mean change in levodopa in UPDRS is much better with levodopa. So that means definitely it is much more effective, and the symptomatic improvement is much more with levodopa compared to Pramipexole, as indicated by the UPDRS motor score. However, when it comes to the total score of activities of daily living and the mental score, there is not much of difference between either of the groups. So they concluded that initial treatment with Pramipexole resulted in lower incidence of dyskinesias and wearing off. Initial levodopa treatment, they resulted in lower incidences of freezing, somnolence, edema, etc. So quality of life, when you compare both the dopamine agonists as well as levodopa, the effect is the same. So there was another trial where Parkinson's disease patients who are receiving levodopa up to 600 milligram, they were added on to additional doses of levodopa, or along with levodopa, ropinirole was added. So they found out that they had a comparable motor fluctuation, comparable motor function with the addition of either levodopa or the addition of the ropinirole, but those receiving additional levodopa experienced significantly more dyskinesias compared to those receiving the dopamine agonist. So in conclusion, total daily dosage of levodopa is more strongly related to the development of dyskinesia, not whether levodopa or dopamine agonist is the initial treatment. Combination treatment using lower doses of each medication may be the best approach to achieving the desired efficacy while reducing the risk of motor fluctuations. So when it comes to starting dopaminergic medications, whether it is levodopa or dopamine agonist, one is not superior to the other. They are equal. Each one has its own merits and demerits. So we have to weigh carefully as to which one has to be started. Now, a word about starting on Stalivo. There has been trials which have shown whether to start Stalivo, whether it is safe or not. Two trials are there: First Steps trial and the Stride PD trial. In the First Step trial, it was a 39-week follow-up trial where they used the levodopa, plain levodopa in against Stalivo, and they found out that there is no significant difference in the incidence of motor fluctuations or dyskinesias. And UPDR score, as expected, was definitely more with the Stalivo group. But when they started with a longer duration trial, which is a Stride PD trial, and they randomized it into different groups, those receiving a dose less than 400, 400, 400 to 600, and more than 600, they found out that dyskinesias were significantly more with the Stalivo group. Not just it was more frequent, but it developed earlier as well. And dopaminergic adverse effects were more common in the Stalivo group. There was no significant difference in the motor fluctuations or motor functions in the two group. So the bottom line is, do not initiate a patient on Stalivo. You can start on either dopamine agonist or plain levodopa. But levodopa carbidopa entacapone is not a good option for a patient to be started on. And the predictors of development and dyskinesias include the same as those with levodopa: young onset, high levodopa dose, low body weight, women, and more severe disease as quantified by the UPDRS, ADL, and motor scores. The recently approved peripheral COMT inhibitor, that is opicapone, it has shown similar effects. It also increases the risk of dyskinesias. So starting a patient on COMT inhibitors will not be a good option. So which one to start? The selection of the appropriate treatment regimen, it has to be individualized. We have to decide based upon a variety of factors: patient's age. So for example, elderly population, never start on anticholinergics or amantadine. And dopamine agonist also will not be a good choice for patients with advanced age. Symptoms of the patients: if the patients have significant motor symptoms, motor disability, it's better we start on levodopa. Symptom severity, occupational status: those who are working on machinery, those who are pilots or car drivers, better to avoid dopamine agonist. Depending upon the lifestyle, cognitive, behavioral, and psychiatric status, those who have significant cognitive or psychiatric symptoms, it's better to start with plain levodopa rather than combination therapy or with dopamine agonist. Other medical comorbidities, including renal functions and liver functions, also have to be kept in mind. So early stages, we can start on MAO inhibitors, rasagiline or safinamide. Mild stages, we can start on either dopamine agonist or levodopa. Again, non-motor symptoms can start earlier than the motor symptoms. So keep in mind that we have to keep an eye on all these non-motor manifestations, and you have to treat them accordingly for the proper improvement in quality of life. Make sure that by the time the patient comes with Parkinson's disease, they can have some of these symptoms: depression, constipation, and REM sleep behavior disorder. Make sure that you initiate on symptomatic medications for these non-motor symptoms as well. Now, do not forget physical therapy. You know that there are no medications which can prevent or arrest the progression of Parkinson's disease, but we can do something with the physical therapy which to improve the outcome. Strategy training, specifically aided at gait therapy and musculoskeletal issues, will improve the quality of life. And one pilot trial where they studied patients who are doing intensive treadmill exercise versus not taking that. They tried the improvement in postural control and motor function, and also with PET scan they studied the dopamine D2 receptor availability. And they found out that those who are taking intense exercise, they have increased dopamine D2 receptor availability, and postural control also improved. Of course, this is not a big number, but at least something objective which we can say that it is likely to improve the course of the disease, and it may arrest the progress, and not arrest it, it may improve the progression or the quality of life of the patient with Parkinson's disease. Thank you.